Hello, I'm Dr. Jeff Boris. I am a pediatric cardiologist and pediatric autonomic specialist in the United States. I have been taking care of PoTS patients for 23 years and have published a fair bit of research in the field. I have taken care of probably over 1,200 PoTS patients so far in my career. Today, I'm going to talk about pediatric postural orthostatic tachycardia syndrome, some similarities, some differences, and some research, as well as how to evaluate and manage these patients. I am a consultant for several different groups here. As you can see, there will be off-label uses of medications mentioned, and some medications that I talk about may not be available in the European Union. So when we're talking about pediatric versus adult PoTS, children are not just small adults, but PoTS itself in adolescents and adults is pretty much the same. It's just in a different body with different things going on. So what's the same? There is a female predominance. It is triggered by infection, concussion, surgery, and trauma, such as a fracture. It is often associated with other comorbidities, including mast cell activation syndrome, joint hypermobility, craniocervical instability, median arcuate ligament syndrome, small fiber neuropathy, Sjogren disease, and systemic lupus erythematosus, to name a few. So then what is different in PoTS patients in adolescents versus adults? Children and adolescents are in school. They are typically more physically active as compared to adults. They have a brain that is in the midst of development, as well as a body that is in the midst of development. They have increased and fluctuating hormonal levels, including sex hormones. They have increasing interoception, which means being more aware of one's body and the effects that our decisions for our actions make on that. They have parents who are influencing and guiding that transition to adulthood, and they are hopefully typically not pregnant. So all of these differences can influence how PoTS manifests itself in these children. There are a couple of other triggers that we don't see in adults for PoTS, including growth spurt and menarche. First, how do we make the diagnosis? The history is very important. It's very severe and debilitating. It's not just typical intermittent lightheadedness. Typically, it also includes multiple systems, including cardiovascular, neurologic, and gastroenterologic. You have to have at least 3 months of chronic orthostatic intolerance. On physical examination, we typically see a heart rate that is greater than or equal to 40 beats per minute in the first 10 minutes of upright position after supine position, and that's a sustained increase in heart rate. The blood pressure may not drop more than 20 over 10 millimeters of mercury. It might actually even elevate it. might actually even elevate. We can see modeling of the extremities, which is consistent with venous pooling, as well as joint hypermobility. And you need both of these significant historical features plus the heart rate changes for diagnosis. So wait a minute, greater than 40 beats per minute for the increase? We thought it was 30, and it is for adults. In a paper published in 2012 by Singer, a tilt table test in normal adolescents demonstrated that 42% of normal adolescents had an increase of heart rate greater than 30 beats per minute at baseline. And the 95th percentile for heart rate was 42 beats per minute. And so 40 beats per minute was accepted as the threshold in 2015 by the Heart Rhythm Society, and again by the pediatric section of the American Autonomic Society in 2018. But that's with the tilt table. Your results might be different with the standing test. A tilt table test is more provocative and less physiologic. It induces a higher heart rate response than an active standing test. And there are a couple of articles, one in adults by Plash and one by Stewart and Meadow in children, that demonstrate this. However, a 10-minute standing test has not been validated, and there has been disagreement in the literature whether a 10-minute stand can even be used for assessing for that increase in heart rate by at least 40 beats per minute. So maybe that threshold needs to be revised downward in pediatric patients. And by the way, I published a paper in 2019 that demonstrated that in a 10-minute standing test, there was no statistical difference in symptomatology or symptom frequency with heart rate increase of 39 beats per minute versus greater than 40 beats per minute. So I think those patients are, my personal opinion is, I think those patients are really the same. In my practice, in my pediatric and adolescent patients, I actually use a threshold of 30 beats per minute, not 40. And we've seen plenty of patients with heart rate increase of only 25 to 29 beats per minute with the same symptomatology and symptom duration. So what do we call them? Is that chronic orthostatic intolerance? Is it the same? And the problem is that we do not have a biological marker for PoTS. We can't sit there and draw blood and say, oh, based on these findings, this is what postural orthostatic tachycardia is. We're still stuck with the use of these markers or these manual markers for a clinical diagnosis. One word of caution, typical orthostatic measurements, which can be done in the clinic where the patient is supine and then seated and then measured in the first minute of standing, are not the same as doing a 10-minute standing test. There are a lot of providers who mistake the initial change in heart rate as being consistent with PoTS. We can frequently see tachycardia and lightheadedness within the first minute of standing that resolves. This is called immediate orthostatic hypotension. It formerly used to be known as initial orthostatic hypotension. In the diagnosis of PoTS, we need to have a sustained or persistent heart rate elevation in the first 10 minutes, as well as symptoms of orthostatic intolerance, typically. From a laboratory testing standpoint, I like to make sure that patients have an electrocardiogram, a 24-hour Holter monitor, and laboratory tests including thyroid function, ferritin, a morning cortisol, and a vitamin D level. So how do we deal with these patients? My approach is validation, perseverance, and reassurance. I tell them I don't give up if you don't give up. I tell them that we need to use both non-pharmacologic and pharmacologic therapy. I have a very patient-centered approach. I ask them, what are your 3 or fewer worst symptoms that are affecting your activities of daily living? But I let them know that what works for one patient does not always work for another. And it's very important to make sure that the other comorbid conditions are appropriately managed as well. So to start, from a non-pharmacologic standpoint, excuse me, from a non-pharmacologic standpoint, we want to make sure that their tank, their intravascular volume is significantly increased, making sure that they have 2.5 to 3.5 liters of intake of fluid per day and 8 to 10 grams of salt a day. We do like to avoid the use of routine IV fluids for these patients if we can. Make sure they are not skipping meals and no caffeine intake. We also want to instruct them in the use of good sleep hygiene, making sure that they turn off their electrical devices about an hour before bed and getting the lights down and trying to relax about an hour before bed. One of the things that can help to reduce the severity of PoTS symptoms in the morning is elevating the head of the bed on a cinder block or risers, approximately 15 to 20 centimeters. Having the head above the kidneys during sleep allows the kidneys to hold on to salt and water overnight to make sure that there is less diuresis. We do teach them to avoid triggers such as prolonged standing and extreme heat. One of the ways of avoiding extreme heat is the use of a cooling vest, and there are different types of cooling vests available that can help to help patients tolerate tolerate the ability to be out in the heat. The use of compression garments can also be very helpful. Historically, I would recommend compression stockings extending from the waist to the toe and giving 20 to 30 millimeters of mercury compression. They should be worn while awake, not while sleeping. And I've had variable success with them. They are difficult to put on. They can cause some abdominal compression or discomfort that may not feel very good for these patients, and it can sometimes make the patients feel too warm. There was some research out of Canada in 2021 that demonstrated that the use of an abdominal binder, however, works better. And what it does is it compresses the abdomen, which then compresses the splanchnic circulation and forces the blood into the core circulation. Again, these should be worn while awake. From an exercise standpoint, the use of consistent and progressive exercise has been demonstrated to be very effective in suppressing the symptoms of PoTS, with the understanding that to be able to get patients to exercise, we need to be able to adequately control their symptoms first. So we'll talk about that in a little bit. The exercise protocol that I utilize is I refer to as the Dallas PoTS exercise protocol. The original protocol was first published, or information about it was first published in 2016 from the University of Texas Southwestern in Dallas, Texas, which is why I refer to it as the Dallas protocol. It combines leg and core strengthening exercises as well as aerobic activity. It starts out recumbent. It starts out minimal with 10 to 12 minutes initially, although you might need to even start with even less than that. And it's an 8-month protocol with calendars telling you what to do every day with exercise. If patients have joint hypermobility, they need to be treated and managed or evaluated and managed by a physical therapist to teach them how to protect and stabilize their joints. When I was at the Children's Hospital of Philadelphia, I modified the protocol for adolescents, and that is actually published online at Dysautonomia International if you do an internet search for Dallas CHOP PoTS. So for medications, there are a lot of different medications available that can be used for patients to help control their symptoms. So again, as I mentioned before, I talk about treating their 3 or fewer worst symptoms. So what are some of these worst symptoms? One of the most common, of course, is the orthostatic intolerance: lightheadedness, tachycardia, palpitations, syncope, dyspnea with exertion as well. Do make sure that the dizziness is not vertigo. Dizziness dizziness is an American term, is very nonspecific. It can include lightheadedness, but it can also include vertigo, which is due to vestibular dysfunction and is very different. Other significant symptoms include fatigue and brain fog. Gastroenterologic symptoms, including nausea, constipation, early satiety, and abdominal pain, but nausea, bloating, and diarrhea could actually be due to mast cell activation syndrome. For headaches, do they have migraine or a tension type headache? Other symptoms, insomnia, somatic pain, and hyperhidrosis. So do keep in mind what works for one patient may not work for another. And people can have strange metabolism. I had one patient who used methylphenidate for her fatigue and brain fog. She would take it in the morning, but it wouldn't start working until that evening. So her metabolism was such that it was just very delayed onset. So I would have her take it the night before, and it would work the next morning by the time she woke up. Polypharmacy is common. The use of multiple medications may need to be done in order to help these patients control their symptoms better. And again, comorbidities must be identified and addressed, and especially mast cell activation syndrome, as well as psychiatric disorders like anxiety, depression, and obsessive compulsive disorder. So let's talk about some of these therapies for these various symptoms. In orthostatic intolerance, there are a few different approaches to this. One thing that I find is looking at what their heart rate is. So if their heart rate is greater than 80 beats per minute at rest, then what we want to do is we want to slow the heart rate down. What that does is that prolongs diastolic filling of the heart, which then increases cardiac output and improves cerebral perfusion. The use of propranolol, 10 milligrams twice daily, has been really helpful for a lot of my patients for this. It is a non-specific beta blocker. It lasts for 6 to 8 hours. So the first dose is taken in the morning, the second dose is taken around mid-afternoon. Side effects can include fatigue, exercise intolerance, worsened asthma, occasional lightheadedness, and rarely depression. It is contraindicated in patients who have type 1 diabetes. What I do is I aim for a resting heart rate less than 80 beats per minute. Others look for a reduced heart rate response with a standing test. Another medication that also works along this line is ivabradine, given 2.5 to 10 milligrams twice a day. Ivabradine blocks the inward funny channel in the sinus node and the AV node, which then slows the heart rate. Side effects are very rare. The one that we see the most is the creation of phosphenes, which is a yellowish haze around objects. It sort of makes everything look like you're looking at the painting Starry Night by Vincent van Gogh. Occasionally, you can have a mast cell activation reaction with this. Again, the goal here is a resting heart rate less than 80 beats per minute. Another way of managing orthostatic intolerance is increasing intravascular volume. I have had very good success with fludrocortisone, 0.1 to 0.2 milligrams every morning. It is a mineralocorticoid with minimal glucocorticoid effect, so patients can be on this medication for long periods without concern for adrenal suppression. The way it works is it induces retention of both water and sodium at the level of the kidneys, similar to aldosterone. The side effects include rash, ankle swelling, headache, irritability. At the higher dose, low potassium and low magnesium may be seen. And so I do recommend these patients have these electrolytes checked after they've been on this medication for at least 1 to 2 weeks. Another medication that can help increase intravascular volume is desmopressin, which is an analog of arginine vasopressin, 0.1 to 0.4 milligrams twice daily. It is essentially a renal V2 receptor agonist as an antidiuretic hormone. It only retains water, so not salt. So one of the big side effects besides headache is hyponatremia. So it is important to, number one, mandate salt supplementation. Don't just recommend it. You tell the patients you need to take this much salt every day. And then check electrolytes to make sure that the sodium is not low. And then the other way of managing orthostatic intolerance is to increase peripheral vasoconstriction. So the medication that works quite well for this is midodrine, 5 to 15 milligrams 3 times daily. It is an alpha-1 agonist. The side effects are mild scalp tingling and goosebumps, although occasionally I'll have patients where it's not so mild. That specific side effect can be more severe and last the entire dosing range and can be very distracting. So if that's the case, then I will not use that medication for them. Other side effects include headache and supine hypertension. What I will do, what a lot of doctors do is they will say, okay, well, because it causes supine hypertension, you may not lie down for the 4-hour window after you take midodrine. I think that's foolish. What I do is I say, take a dose of midodrine, 1 hour later, lie down for 5 minutes. At the end of 5 minutes, measure a right arm blood pressure. And as long as that right arm blood pressure is under 120 millimeters of mercury systolic, if you need to lie down, you can do so. It only lasts for 4 hours, so it must be taken every 4 hours, 3 times a day. Another approach in my patients who are doing pretty well, but otherwise have worsening orthostatic intolerance just with exercise, is using a single dose 30 minutes prior to exercise. And that has actually been able to be very helpful for them. Another medication that's relatively newer is droxidopa, 100 to 300 milligrams 3 times daily. This is a norepinephrine precursor. The side effects include dizziness, bladder pain, and supine hypertension as well. I will say that I don't have as much experience using droxidopa personally for my patients. When we look at fatigue and brain fog, first of all, for the fatigue, we need to fix the insomnia, and we will talk about that a little bit later. However, I have had very good success in the management of fatigue and brain fog using stimulants or medications that are used in the treatment of attention deficit hyperactivity disorder. Methylphenidate 5 to 20 milligrams twice daily can be really helpful. The long-acting version of methylphenidate, 10 to 40 milligrams in the morning. Mixed amphetamine salts, 5 to 10 milligrams twice daily, and with extended release versions of 5 to 40 milligrams in the morning. Also, dexmethylphenidate and lisdexamphetamine can be really helpful. Those are single once daily dosing. Side effects include decreased appetite, headache, tachycardia, or a revved up feeling, irritability. Sometimes we'll see patients complain of crashing off of it. That typically occurs with the short-acting formulations. Rarely, it can also worsen tics. Another therapy that can be used is atomoxetine, 10 to 100 milligrams every morning. This is a selective norepinephrine reuptake inhibitor. Side effects can include headache, insomnia, abdominal pain, and nausea. In our study, which I'll talk about a little bit later, a little over 16% showed efficacy. So most patients had no effect with this, but that doesn't mean that it's zero, right? So I think there's a small proportion of patients who will have benefit from atomoxetine. And then the use of modafinil, 50 to 400 milligrams every morning, or armodafinil, 150 to 300 milligrams every morning, can be very beneficial for fatigue specifically. I find that it doesn't do a lot for brain fog, but it can potentiate the dosing for stimulants, which means that you would need a much lower dose if you co-administer something like methylphenidate or mixed amphetamine salts. The side effects are similar to stimulants. Nausea is very common amongst these patients. Ondansetron, 4 to 8 milligrams twice to 3 times a day can be very helpful for these kids. This is a serotonin blocker, 5-HT3 blocker. Side effects include headache, constipation, and QTC prolongation. If patients are using them routinely, i.e. once a day, twice a day, 3 times a day routinely, just get an electrocardiogram to make sure that they are not having any QTC prolongation. And by the way, as a cardiologist, I recommend that if you do see prolongation of the QTC interval on the electrocardiogram, you need to hand measure it, because the computer of the electrocardiogram often, if the QTC is prolonged, the computer often has mismeasured it. So make sure you hand measure it to confirm this. Another medication that can be helpful for nausea is scopolamine, which is a 1.5 milligram patch. It typically is placed behind the ear. It is an antimuscarinic effect. The side effects can include blurry vision and also contact dermatitis. If patients are having these side effects but having benefit with their nausea, you can reduce that dose by placing it over the shoulder blade instead of behind the ear. Cipraheptadine is an antihistamine that has been around for a long period of time. It's an H1 receptor blocker. 4 to 12 milligrams at night can be helpful. Side effects can include sleepiness, which is actually good for patients who have insomnia, although sometimes it can also increase the appetite with unwanted weight gain. It does increase gastric accommodation, but it can also prevent migraine, which we'll talk about in a little bit. Meclizine, 25 to 50 milligrams once to twice daily, is also an H1 antihistamine that can be useful in the management of nausea. Side effects can include drowsiness, dizziness, headache, and dry mouth. Dronabinol is relatively newer. It is a cannabinoid, which is specifically synthetic THC. Side effects include dizziness, palpitations, anxiety, and sleepiness, but that can sometimes help with nausea as well. We do see gastrointestinal dysmotility, as we talked about before. That can be due to either gastroparesis and or intestinal dysmotility, which causes nausea, early satiety, abdominal pain, and constipation. I've had pretty good success using pyridostigmine, 30 milligrams twice daily up to 120 milligrams 3 times daily. This is an acetylcholinesterase inhibitor. And I find that it works pretty well as a pro-motility agent. Side effects include abdominal pain, diarrhea, and then muscle twitching, which is rare. If they do have muscle twitching, it is reversible upon stopping the medication. The antibiotic erythromycin, which is a macrolide antibiotic, can also be used as a pro-motility agent. Side effects include abdominal pain and nausea. Prucalopride is a much newer medication that is recently being used. I think it is a downstream derivative of an older medication called cisapride, which was available in the late 1990s and early 2000s. Prucalopride 1 to 2 milligrams per day is a serotonin receptor agonist. Side effects can include abdominal pain, diarrhea, and headache. It is not, in the United States, is not approved for patients under 18. But there are a lot of medications that we use in the United States that are not approved for under age 18, and yet they still have very good effects. As I mentioned before, cipraheptadine can be used for the GI dysmotility, specifically in increasing gastric accommodation, and so that can actually help with that. If possible, please try to avoid medications that draw water into the intestine, such as polyethylene glycol and others, in the management of constipation, because it goes against what we're trying to do with the management of PoTS, which is trying to keep fluid in the vasculature and not losing it through the intestine. Migraine headache is a frequent frequent symptom that we see in the setting of PoTS. Migraines can be managed both acutely and prophylactically. Here, I will only discuss prophylactic management. For any prophylaxis, at least 6 to 8 weeks needs to be given to assess for efficacy. Magnesium, 200 milligrams twice daily, vitamin B2 or riboflavin, 200 milligrams twice daily, and coenzyme Q10, 150 milligrams twice daily, have been shown to be very helpful in in the United States, at least, as over-the-counter therapies that can help to prevent migraine. Cipraheptadine, as mentioned previously, can also be used as migraine prophylaxis and can be quite effective, really. Verapamil, 120 milligrams at night, is a calcium channel blocker. It has some efficacy. It originally was thought to be much more, was thought to be more helpful, but as time has gone on, the research has demonstrated that it only works in a small proportion of patients. Side effects can include dizziness, and then it cannot be used with beta blockers at the same time. Amitriptyline, 10 to 50 milligrams a day. This is a tricyclic antidepressant that causes serotonin and norepinephrine reuptake blockade. Side effects include drowsiness, constipation, and dizziness. Topiramate, 25 to 50 milligrams a day to twice daily. As a GABA stimulator. Side effects include nausea, brain fog, and drowsiness. And the brain fog that is caused by topiramate can be pretty significant and can be very limiting in its ability to be used. Other therapies include CGRP inhibitors, botulinum toxin injection, and nerve block. You'll notice that I did not include beta blockers or beta blockade as therapy, because typically higher doses of beta blockade are needed for migraine prophylaxis, and that would typically end up causing lower blood pressure in these patients, which is obviously not what we want to do for them. As an aside, the other main type of headache that we see in PoTS patients is tension type headache. And just for completeness, I have actually been referring patients for osteopathic manipulation therapy for this, and I've had pretty good results with this. Insomnia is definitely something that we see in patients, both difficulty getting to sleep as well as staying asleep. Clonidine, 0.1 to 0.3 milligrams at night, which is an alpha-2 agonist, can be very helpful for this. Side effects can include dry mouth and dizziness. Trazodone, which is a tricyclic antidepressant and combines serotonin, histamine, and H1 antagonist, can also be helpful for this. You can have constipation and dizziness. It can also cause a sleep hangover, which means that you're very tired the next day. And so even though it might help with your sleep, it can potentially worsen your fatigue the next day. Mirtazapine is another one that is it's a combined alpha-2 and serotonin antagonist. Again, sleep hangover can be seen with mirtazapine. Another thing is it can also increase appetite, so we have to be careful with that one, similar to ciprofloxacin. Dizziness and nausea can be seen as well. And that, as I mentioned, ciprofloxacin can be used for insomnia. Ciprofloxacin I will often use if patients have multiple issues that need to be addressed, i.e. such as nausea and insomnia at the same time. For patients whose days and nights are reversed, I will use either zolpidem or ezapicolone for approximately 2 weeks to try to reset their sleep schedule. These are both GABA inhibitors. They have very rapid onset, so the patients take them and they need to be in bed within 1 to 2 minutes. Side effects can include somnambulism and dizziness. Increasingly in patients who have had a history of abnormal sleep prior to their onset of PoTS, I have been recommending an evaluation by a sleep medicine specialist to include a sleep study to make sure that we're not missing anything else. Somatic pain is seen in a lot of these patients. Pregabalin, 75 to 150 milligrams twice daily, which is a calcium channel blocker that works at the level of the neurons, can be helpful with this. It can cause dizziness, weight gain, fatigue, and brain fog. Duloxetine, 30 to 120 milligrams a day, which is a combined selective serotonin and selective norepinephrine reuptake inhibitor, has also been somewhat helpful. Side effects include headache, nausea, insomnia, and dizziness. I've also used low-dose naltrexone, 1 to 4.5 milligrams every morning, although some reports suggest that dosing as high as 10 milligrams every morning may be helpful. This is an opioid receptor antagonist. At lower doses, it reduces glial cell-related inflammation. Side effects can include insomnia, so it needs to be dosed in the morning, headache, and vivid dreams. It can be used as adjunctive therapy in mast cell activation syndrome, and it must be compounded. In the United States, it comes as a 50 milligram tablet, so it needs to be compounded into a smaller amount. Be aware that somatic pain that includes numbness, tingling, and hypohidrosis may actually be small fiber neuropathy. And these patients might need a skin biopsy for diagnosis with immunomodulatory therapy to better control it. Joint pain can be due to joint instability, secondary to hypermobility, so physical therapy is important for those patients. In patients who have hyperhidrosis, aluminum chloride hexahydrate is a topical antiperspirant. The main side effect is that it can cause skin irritation if the skin is wet. Scopolamine, the patch that I mentioned previously, can also be used for hyperhidrosis. And then oral glycopyrrolate can be used as well. This is a muscarinic receptor antagonist. It can cause tachycardia, dry mouth, and nausea, but it can also reduce the sweating that these patients have. There are some newer data that suggests that this may be due to some sodium channel mutations. So hopefully research in the future will show us better information about this. There are some parenteral therapies that have been used as well that can be used for either temporary support or more long-term therapy. Normal saline, 1 to 2 liters given IV every 3 to 14 days. This can improve cerebral and hypothalamic perfusion, which can then reduce the orthostatic intolerance and reduce norepinephrine output by the hypothalamus. Side effects include venous scarring if it's done for prolonged periods peripherally, or infection and thrombosis if a central line is used. We're not quite sure why giving 1 to 2 liters of normal saline lasts 3 to 14 days in these patients. My theory is that by improving the cerebral perfusion and reducing the hypothalamic output of norepinephrine, and then continuing oral therapy of fluid and salt, there is it takes much longer for the intravascular volume to decrease, but that's my theory. Triatide is a somatostatin analog which causes splanchnic vasoconstriction. Side effects include loose stools, which actually might be a benefit in patients who have constipation, abdominal pain, and injection site pain. So it works similarly, in a way, it works similarly to abdominal binders by reducing splanchnic pooling. Oops. And then erythropoietin, 5,000 to 20,000 units given subcutaneously every week. This is a glycoprotein hormone that stimulates red blood cell production, but it also causes peripheral vasoconstriction. It can cause hypertension, headache, and erythrocytosis. So we want to make sure that the hematocrit is maintained at less than 50%. How about intravenous immunoglobulin and subcutaneous immunoglobulin? There are multiple anecdotes and case reports and case series suggesting significant clinical improvement. This does make sense if we think that PoTS is autoimmune or autoinflammatory, and I think there are a lot of good data to suggest that, although we haven't proven that PoTS is totally due to an autoimmune or autoinflammatory etiology at this point. There was one double-blind randomized placebo-controlled study published in February of 2024 that showed that there was no difference between IVIG, intravenous immunoglobulin, and albumin as the placebo. However, there were many flaws in the design of that study. So I'm glad they did the research, but it was not particularly well designed. IVIG can definitely cause aseptic meningitis if it's given too fast to these patients. So we definitely need more data in assessing the efficacy and safety of IVIG or subcutaneous IG in these patients. As I mentioned before, polypharmacy is frequently needed to improve their symptoms so that they can exercise. And then I've absolutely had patients who are able to exercise and several months down the road, when they've been exercising for at least 4, 5, 6 or more months, you can sometimes wean medications as tolerated. As I tell my patients, my job is not to shove medicines down your throat. My job is to give you options. However, if it's bad enough to cause disabling symptoms that interfere with your activities of daily living, then we should consider treating it. And it's important to make sure that these patients do take ownership of their own care. I find that the patients who manage their symptoms themselves without their parents looking over their shoulders tend to do better. For other issues, I do try to be the PoTS primary care provider, but if I can't, then I will refer patients for who have persistent persistent gastroenterologic gastroenterologic issues, to a gastroenterologist with a motility specialty. If there are bladder issues, I will refer to urology, and sometimes bladder biofeedback can be helpful. Mitochondrial evaluation might be important in patients who have typically progressive worsening or familial or other suggestive symptoms of mitochondrial disorder. In patients whose headaches are problematic, I will refer them to a neurologist who manages headaches. I will sometimes refer patients to a connective tissue disorder clinic if they have Ehlers-Danlos syndrome or hypermobility spectrum disorder. Certainly, if there are comorbid psychiatric concerns or acquired issues, behavioral health can be helpful, such as a psychiatrist or a counselor. Certainly, the counseling for management of a chronic illness, such as PoTS and these other issues, is very important, and that's for both the patient and the family. If the patient has mast cell activation syndrome, then an allergist immunologist who's familiar with this can be helpful. If a patient has median arcuate ligament syndrome, an interventional radiologist can be helpful in doing a percutaneous celiac ganglion plexus block to assess for symptom relief. And if they do have relief from this, and these patients tend to be a good candidate for surgical intervention. So are there emergencies with these patients? I mean, not really, right? So these patients acutely can need IV hydration, and they often get relief for 3 to 7 days, as I mentioned before. Sometimes they need a headache management protocol, or they have other GI issues such as constipation and something like that. Admission for these patients to the hospital is uncommon. Typically, it would be for prolonged gastroenterologic or neurologic management if they have uncontrolled hypertension or if there's a psychiatric comorbidity. I actually have data from a study that we published several years ago, in which we looked at emergency department, there we go, some actual data in 2023, where we looked at 297 patients who with age and sex match controls over 3 years. And we found that PoTS patients were seen in the emergency department for GI and headache concerns, as well, but only some autonomic concerns, whereas, actually, there we go. That's our p-value. Whereas control patients were seen much more for autonomic concerns. And interestingly enough, control patients were seen more for psychiatric issues as compared to, there we go, psychiatric issues as compared to PoTS patients. So, why do these patients or families feel that there is so much urgency for these patients? They have worsening or persistent symptoms. And these symptoms can be scary if you're not used to them. There can be a variable response to therapy. Symptoms can be cyclical, or new symptoms can show up. The parents are very invested. They have had to have been a protective advocate for months or years. They have been previously told that their child or the parent is making it up, making it worse. It's psychiatric in nature. It's everything but what it really is. And then they have very high expectations. So now that we have a diagnosis and a treatment plan, why isn't she better now? Why are they not back to school? And when we're talking about school, don't forget the assistance that patients will need from a schooling standpoint. They often need accommodation, such as 2 sets of books, one for school and one for home, an elevator key, extra time to walk between classes or for tests. They might need someone to help walk with them. The ability to have water and salty snacks, a nice, cool, quiet place to self-limit and to recover, such as the library. Some patients need either partial day school, virtual school, or homebound education as well. One thing that can be helpful is replacing physical education class with the Dallas protocol. They might need accommodations for standardized testing, and for college, having a first floor dormitory room, air conditioning, a private bathroom, and the ability to tape record lectures. College is often easier because patients have self-awareness. They own the disease. It's all them. Their parents are not there managing it for them. And there's more recovery time between classes. I want to talk about some of the research that we have published over the last 9 years or so. I created the PoTS program at the Children's Hospital of Philadelphia in January of 2014, and I saw almost 950 patients in a little over 4 years. Although actually that's not true. 949 patients since 2007 when I first arrived. And we initiated this PoTS program after increasing local and regional patient volume and added a nurse practitioner to help manage follow-up visits. We created a database and reviewed, as of 2016, 722 patients. 708 of them were age 18 and under. It's the largest known clinical pediatric PoTS database in the United States. In 2018, there were 932 patients under age 18. We published a retrospective review in 2018 with data derived from clinical information obtained through the electronic health record. When we looked at race versus ethnicity, Caucasian patients were way overrepresented, although there may be some definite bias in this, in patients who are not white being misdiagnosed or culturally not coming into the emergency department or any other provider for this. The median age at presentation, so that's when they're actually diagnosed, is 15.5 years. We had a 3.45 to 1 female to male ratio, although the adult literature lists 4 to 5 to 1. The median age of onset of symptoms was 12 years. So the median duration of symptoms prior to diagnosis was nearly 3 years. The main inciting factors or temporally related triggers included infection, concussion, and surgery or trauma. The infections that we found included Epstein-Barr virus, upper respiratory tract infection, Lyme disease, gastroenteritis, and then several other disorders, infectious disorders. Over half of patients demonstrated joint hypermobility, with 22% of patients having hypermobile Ehlers-Danlos syndrome and a little over a third having hypermobility spectrum disorder. About 5% had an inflammatory disorder that included celiac disease, thyroid disease, Crohn's disease, diabetes, and eosinophilic esophagitis. The top 6 initial complaints or presenting symptoms included dizziness, headache, fatigue, abdominal pain, syncope, and nausea. And then subsequent symptoms, 2/3 of patients had at least 10 symptoms, 50% of patients had at least 14 symptoms, and 30% of patients reported at least 26 symptoms. So a lot of these patients are very symptomatic. The top 14 reported symptoms you can see here. And they, again, cover cardiovascular, neurologic, and gastroenterologic systems. There was no difference in the median age of first onset, duration of symptoms, or age of onset by gender. However, boys were more likely to have an infectious trigger than girls. If patients had joint hypermobility, females were more likely to be hypermobile as compared to males. The median duration of symptoms was longer, and the median age at onset was younger in hypermobile patients. A separate paper that we published on the outcomes of medications and their effectiveness, you can see here. In the management of most symptoms, dizziness, headache, nausea, dysmotility, pain, and insomnia, the effectiveness was between 39 and 53%. However, for fatigue and brain fog, about 69% efficacy in managing these symptoms. When we looked at patients' family history in 2020, in nearly 580 PoTS patients, other family members had 14% had 14% of PoTS patients had a family member with PoTS, and 2% had at least more than one family member. Dizziness and syncope, 17%. So combine that, 31% of PoTS patients had a family member who had some sort of orthostatic intolerance. 20% of patients had a family member with joint hypermobility, and 45% had a family member with a history of an autoimmune disorder. We just recently published last year the first of our long-term outcomes survey papers, and actually our gynecologic paper was just published a couple of weeks ago. It's one of the largest and longest long-term outcomes surveys. 227 patients with a mean duration of 9.6 years. The average age is 21.8 years. We covered diagnosis, treatment, and outcomes, educational, employment, and social outcomes that has been submitted for publication, and then gynecologic associations, which were just published. Female patients in our first paper, female patients had more symptoms than males, at least 10 symptoms, 88% versus 64% females versus male, and more females had 15 symptoms than males. They had worse symptoms than male, more pain and worsening GI score, and they had longer symptom duration than males. They still needed increased salt, water, and exercise to control their symptoms. And really, nearly everyone was still symptomatic. So in the month prior to completing the survey, 99% of patients remained symptomatic, which means that PoTS does not go away. We are only treating the symptoms. We are not treating the underlying cause. The most beneficial interventions included medications, increased fluid and salt intake, and exercise, as you can see here. PoTS does cause an overall moderate decrease in quality of life, both in children and in adults. Over half of patients had a trigger, infection, injury or surgery, or pubertal changes, as we've talked about before. And then in being seen by other providers prior to diagnosis, nearly 2/3 of patients were told that their symptoms were actually psychiatric, which is not true. Over half of them were told that the symptoms were in their head, meaning they were making it up. And 3/4 of them had seen a doctor who had never even heard of PoTS. After diagnosis, nearly half of them were still told that their symptoms were psychiatric, and 31% were told that their symptoms were in their head. 46% were currently being treated for a psychiatric disorder. And this is not to say that anxiety, depression, and OCD can't occur in the setting of PoTS, but the PoTS itself needs to be recognized and managed as well. From an educational and an employment and social standpoint, 97% of PoTS patients missed school because of PoTS, and around half of them missed greater than 100 days. Nearly 3/4 of them dropped out of sports, and over half of them dropped out of extracurricular activities. But by age 21, 97% had their high school diploma or their graduate equivalency degree, which is really pretty impressive considering that they have a chronic illness. 80% had attended college or university. 91% of those had either graduated or were still attending at the time of the study, and 19% had attended graduate school. From an employment standpoint, nearly 60% were employed in the last 3 months. Again, remember the age of the patients. The average age was around 22 years, so they're pretty young. 45% of them were working at least 31 hours a week, and a little over a third would have worked more if not for their health issues. About 2/3 of patients missed work due to PoTS, and around half of them missed at least a week. Nearly half of the patients had to modify their job due to PoTS, including workplace modification or a reduced schedule. From a social standpoint, approximately 60% of patients lost friends due to PoTS, 21% lost a serious relationship due to PoTS, and 70% lived with their parents, although including a third of them who had moved out and then moved back in because of their disease. From a gynecologic standpoint, we found that there was no increased abnormal uterine bleeding, but again, our patients were much younger, And that a study that was published from Vanderbilt University showed that with older patients, there was increased abnormal uterine bleeding, polycystic ovary syndrome, and endometriosis. 72% of PoTS patients had worsening symptoms around their menses, with 98% occurring in the 10 days prior to or the 5 days during their menses. 2/3 of patients were using hormonal contraception, with half of patients demonstrating either somewhat or much better reduction of their symptoms around their period. Anecdotally, we know that a low estrogen containing oral contraceptive or intrauterine device can be helpful for these patients. So the bottom line is that PoTS is not fatal. It's just debilitating, annoying, anxiety, depression, and provoking. And the patients and families really need validation and encouragement to continue to work with these therapeutic options and to continue to work with fluid, salt intake, and exercise. All right, I think that's enough. Go out there and help these kids. Thank you so much.